you so much. I've been here before and I love to come here. Now, I will tell you the importance of these talks before the workshop. It is very important because when you will go there, I think you will start training the fellow delegate who's there with you if you listen to this talk step by step. So, okay, thank you. Thank you once again for the kind introduction. Can I have my presentation? So, when we were in school, medical school I'm talking about, and colleges, you all will agree with me that we didn't really get whether it was gynecology, obstetrics or radiology also, to really have hands-on or get to see or try to understand how these procedures are done. Where our attention as delegates was to see, yes, amniocentesis and fluid was there. Chordosynthesis and blood was there. And then when we do CVS, chorionic villi came. But how really it so happened successfully and that the tissue, the chorionic tissue, the amniotic fluid or blood came, that how it is possible to do it. And then once you are out and you become busy in your practice, you hardly put in your time, and then when there is a patient, if you know how to do amniocentesis, you will say, no, I'll do amniocentesis, chorion biopsy is not safe, because you may not have done a chorion biopsy. So we people, we all are similar. We will say amniocentesis because we don't think, the eye sees what the mind knows. Like the same way the hands perform what you know, what you are skilled in. So if you know these procedures, then you say, oh my God, I could have done an early diagnosis and CVS, I could have done amniocentesis and so on. So first I'm going to tell you about what really happened is this inverted pyramid of prenatal care. Before 1990s, we used to all practice what you are seeing. We should hardly get any patients in our OPD 12 weeks, 16 weeks, and maybe around 20 weeks, and most of them would come, 7वें महीने पे नाम लिखाने के लिए आए हैं. So where was the prenatal care? What we are talking about, fetus as a patient. We have reached to have conferences now on fetus as a patient. So that was before 1990, and then came this new era, the pyramid shift, and we started seeing and we started practicing and we started giving awareness to our patients the importance of prenatal care in the first trimester. Because if the patient has not come in the first trimester, now in our current practices, we would just take a step back. Okay, I don't know what she's carrying and whether everything will be okay. So the new era which came, and Kypros Nikolaidis, when he started working on screening. So first 12 weeks of pregnancy became very important, and then you all know, we all practice now, that every 2 weeks what we have to do, we have to see first scan to see whether it is intrauterine or extrauterine, and then cardiac activity and the growth, and then we do NT scan, and then we also now are in an era where we do a fetal anatomy scan even between 12 and 14 weeks, and almost up to 97-98% we are sure that at least there are no anomalies, which are to be confirmed of course later. Only those in screening who are found to be at high risk are going to deserve specialist care, otherwise the same pattern is followed. So this is the new era and the pyramid shift of prenatal care. So this is what I spoke to you. This is the algorithm. You must take a picture of this. In practice, the pathway to healthy pregnancy outcome, like what I told you, early pregnancy, it begins with good counseling. When you have counseled the patient and you will tell her that this is what you require, she will be most ready to do it, or rather she may remind you, okay, doctor, why aren't you doing my sonography to see the cardiac activity? Why aren't you not doing my NT scan, and when will my dual marker will be done? So if you follow this pathway, and then always screening is not a diagnosis, it is screening. So never call it positive, negative. High risk, low risk is the terminology what is to be used. So those at low risk will follow the routine path, and they will have a routine antenatal care and delivery, and those which will be at high risk will deserve invasive prenatal diagnosis for the sake of diagnosis. And what is available is amniocentesis and chorionic villus sampling, and then you are also having in screening now NIPS and all that. So that is all screening. And it is very important to have a good counseling pre-procedural, and equally important is post-procedural when the report comes, what to tell to the patient and how to infer the entire thing. So in the era of this paradigm shift where screening is done so rampant and we do almost every patient, will invasive prenatal diagnosis reduce? Common sense says yes, because you will only do on those who are at high risk. But if you look at the broader picture, this is the sensitivity we have, therefore only low risk, high risk, and then we have to do actually more number of invasive procedures. That is why you are here to learn, because need for invasive prenatal diagnosis is on the increase. And of course, earlier we used to do age and history related. Now we are doing for almost all. Why almost all? All the pregnancies. And earlier it was only in the elders, above 35 we had in our mind would deserve an invasive. But because now we are doing screening, and we know that 70% of those who are pregnant are in younger age group, and nobody is immune to aneuploidy. So therefore, the spread screening all, also there is a possibility that younger patients also deserve invasive prenatal diagnosis. So biochemical markers, NIPS, and where you need to do karyotyping or microarray study, so the role of diagnosis comes. You have to open your eye to see these chromosomes, whether they are in place, in number, and in structure. By doing FISH, which gives you a diagnosis in 48 to 72 hours, karyotyping, which will 10 days to 12 days you can get the report, and you come to know about all chromosomes. Never take a shortcut in this. You may think that, okay, I will do only FISH. You will start thinking what the patient is not thinking. It is expensive to do karyotyping, or it is expensive to do microarray. You start assuming, presuming, but something goes wrong. So the patient will say, who told you that I don't afford? I can do anything to see that my baby is all right. So you have to not hesitate in telling that when we do FISH, we also have to do karyotyping, because karyotyping is going to see all the chromosomes and also the defects in the chromosome. And now we have microarray, which is the magnified version of doing the genetic study. And in practices, we have amniocentesis and chorionic villus sampling. And law of the land, you must know that all this is to be done under the control of and as per required by PCPNDT, which means to say the center should be registered as an ultrasound or genetic clinic, and a registered, trained, experienced person only can perform these tests. So about these two tests, let's talk about amniocentesis. This is what you are looking out on ultrasound to see that there's a good amniotic fluid pocket. In the olden times, it used to be a touch technique. We used to palpate. Incidentally, my thesis, I never knew I will be doing all this intervention and fetal medicine, was estimation of fetal maturity. That time only X-ray used to be available, and I was given my thesis as Nile blue sulfate test and surfactant study on amniotic fluid. So I never knew that this is going to what I'll be called to speak on after getting into this. So when you do ultrasound, that was touch technique. It was more or less possible to do it, but 70% success. After amniocentesis, ultrasound guided has changed the game. Now there is no fear, there is no worry. You can see and do a very safe procedure if and if only you're going to follow the ultrasound principles. I'm going to take you after this to a talk which will tell you the ultrasound principles, and that will make it so easy when you are going to be besides those simulator mannequin as your patients. So things which are required in amniocentesis, no waste. I won't take much time in this. You know that we need spinal needle. We need 2 conical tubes with a screw cap. In chorion biopsy, this is what you are going to imagine to see or visualize on ultrasound, and you are going to locate the chorionic frondosum pointer. You are going to locate the chorionic frondosum, because these are dividing, budding, generating villi, and this is chorionic frondosum, and these are degenerating villi, decidua, what we call chorionic levi. How will you come to know? How will you differentiate? Suppose the chorionic frondosum is not as thick as like this, so easy. How will you differentiate? Anyone? By seeing the cord insertion. So there is a cord insertion which is going to be future placenta here. This is chorionic frondosum. However thick, thin, doesn't matter. If there is a doubt, you must see that cord insertion. So there are 2 methods when we are talking about chorionic villus sampling. One is the transcervical chorionic villus sampling and the transabdominal. Commonly practiced, if you speak to the imaging people, I am told there are some imaging people also who have registered for workshop. They will say transabdominal, very good. Those who are gynecologists, we are well versed with, and our patients repo with us, doing an internal examination and doing procedures, and much, much more anatomical, easy, and you have a good access to the chorionic frondosum, and you can really get good quantity of villi, is the transcervical method. So who decides? Not the person, depending upon their ability to do transabdominal or transcervical. What decides is the location of the chorionic frondosum. If the chorionic frondosum is fundal, anterior, very high, you must do transabdominal. If it is posterior, it is only if you go through and through the entire amniotic cavity that you are going to reach there, or you will have to really maneuver and take a lateral approach, and it can become difficult. So you have to decide depending upon the location. Not only that, if it is how acutely anteverted or retroverted the uterus is, whether it is fixed with adhesions, all this is going to decide, because you have to really maneuver to get a favorable position for a biopsy. So you will have to see all these things. And of course, finally, it is the operator's expertise after that also. If you are not well versed with a particular method, you should send to the person who does such type of a approach. Now, this is a very, very simple device. It is a transcervical cannula for chorionic villus sampling. It is malleable, economical, reusable, autoclave, 16 gauge. So the quantity of villi aspiration is so very simple and easy, doesn't require any suction. And of course, for the spinal, needle is required with 18 or 21 number bore, depending upon the gestation for the transabdominal. Common to both what you require, what is really related to the lab, nothing but 10 cc syringe. You may require a mechanical suction, because nowadays we have to do chorionic villus sampling after the combined testing. So it is 12 to 14 weeks. By that time, the tissue is not as simple as when we used to do at 10 weeks, 11 weeks. And sometimes we have done earlier also, not knowing what can happen. So it should not be done before 10 weeks. Then you require a tube like this with a screw cap, with the media, culture media provided by the lab, the Petri dish. This and the villi floating in this, kept on this torch, makes you see these villi so beautifully that you don't require a dissecting microscope. And then a pickup forceps like this. This is to just illustrate how a transcervical procedure is done. After evaluation, aseptic precaution, You preform the cannula. Cervical cannula can be preformed depending how you have mapped the chorionic frondosome and the path, the GPS to this chorionic frondosome. Accordingly, you will curve it. You will see this cannula, we have it up here. You will keep it straight. You will curve it up. You will give a slight curve. If it is retroverted, how will you negotiate? How you will negotiate up to the internal os and just turn it around and take it back. All those maneuvers you will be able to see. And this is how it will be on ultrasound. Chorionic frondosome, cord insertion, therefore chorionic frondosome. And this is the malleable cannula. This is the diagrammatic representation. This is for the transabdominal in the same way. This is how you will see it on ultrasound. And this is what you should expect in your Petri dish. Branching, budding, villi. These you can only obtain in chorionic frondosome. And these can only culture because they are budding. And these will also show you, if you see it well, even with naked eye, you will see some capillaries coursing through it. This is how it should be. So this is how a microscopic picture, this is for instant, like doing fish, whereas you have to take the mesenchymal core, as it is described here, for culturing these cells. Doing in twins is no big difference. It is like doing two procedures. Both could be from the same root. Both could be one from the transabdominal, one from transcervical, depending upon location. I would choose to do a transcervical and go up, and I would limit my aspiration here and then stop the aspiration and bring the cannula out. And then I take a separate set of device and I will limit my boundary. This is like LOC, line of control. Don't go too much close to it. Just aspirate there. You can do a good without mixing, but you should counsel that this could be an error, in diagnosis because it is twin pregnancy, but you have to take care to see that this doesn't happen. So I was telling you, don't do anything before 10 weeks because this leads to vascular insult. We may not realize, sometimes we are so enthusiastic that we take out lots of tissue and we are very happy. But after all, it is lost to the fetus. So due to this vascular insult, there could be some deformities which were noted. So never ever do CVS before 10 weeks. This you can take a picture. There are on YouTube live procedures. Live procedures are there. You can go and see it there. It will take 10 minutes to show you on here. There are 6 procedures on this particular YouTube. So take-home message is scan just before, because you could have scanned, you could have got a sonography report from a sonologist, things would change. Location of the amniotic fluid pocket could change, chorionic tissue like placental migration, even chorionic frondosome migrates. So you may have to relocate and understand all this. And during the procedure, do not advance the needle blindly. Because sometimes we become desperate. We are seeing the needle, we have gone there, and we are not seeing. And we start, should I say, sword fighting. Somewhere, because now the patient ko jawab dena hai. Onlooker is there, nurse is there, some students are there. I must do something to get. No. You can demonstrate that, leave your hands off the needle. That is the lesson you should leave there. Relocate and then advance. So this is about, now the most important thing what I love to demonstrate, show here and demonstrate in the workshop is now.
Thank you, sir.
Nee, thank you for what? You will thank me a little later. Little later. Little later, huh? Sorry.
Okay. Thank you.
Thank me for this. Okay. So this is what we are. We are at the diagnosis, and now you are the operator. So you should know to maximize success the correct transducer. You may do everything well. but the machine, the gain setting is not proper. The needle is there, but you are blind to it. Gain setting is very important. And then you should have enough experience, and your marriage with the sonologist, like how, you know, good coordination. It's like that. All marriages are like that, na? Coordinate, yes. So we go on like that. So principles are now coming up here. So it's a rule of 3. The probe, the target. This is what you will see there also in the workshop. And then finally, the needle. If you are seeing this way, and the rule is 2 will remain static, only 1 will move. Just imagine if you are moving the needle and the transducer, what will happen? So the probe and the target are constant, and the needle will move like a dart. Absolutely, you will say, oh, it's like that. So the probe, curvilinear probes, earlier we used to use sector, before that I used to use linear probes, but now we have got this curvilinear, which gives you both benefit of sector and linear. You should apply this probe very gently on the gelled abdomen. You should feel for that patient that time. You are desperate to see your target, but that time you are not realizing that a painless procedure, you are making it painful. And then the patient will say, please give me anesthesia. You cannot give anesthesia because of probe pressure, isn't it? That can be controlled. And another thing, if you give too much pressure, you will just glide away, because you have made the surface slippery yourself. So you put the gel, you just apply, don't require to glide. So localizing amniotic fluid pocket free of structures or a chorionic frondosum. And while doing this, the amniotic fluid, if the fetus moves, no harm. Fetus, good fetus always moves. Only when the fetus is not, if the fetus doesn't move, you are worried, you know, isn't it? So expect it to move, but then you should just take it easy. And sometimes it requires a little tap, like how you tell the baby to feel happy or cry or something like that. So I have already told you, spinal needle or a cannula, both are hyperechoic, brilliant on echoing in the image, and they penetrate and proceed to the target. Probe remains static. You must always visualize the entire path, from skin to the parietes, to the myometrium, and inside. It's not that just you have put inside and then you're finding where is the tip of the needle, entire needle. Many times this will happen, needle visualized throughout the procedure, but then suddenly this is like, you know, entry point towards the target, reaching the target and exit. At times you have faced challenges like this. Location of the target is center, side or posterior. Accordingly, your approach is going to be anterior, lateral, accordingly. So therefore scan and plan before doing the procedure. Now this is very important thing to know. When we handle a probe, you should not presume that entire thickness of that probe is ultrasound. Just a thin blade fanning out like this, which could be a millimeter or millimeter and a half thick, is what is ultrasound. Rest is the casing of that transducer. So don't think that full rubberized thing is an ultrasound coming out. Only this thin. So you have to align your needle in this thickness without moving, like this. So needle is inserted in the same plane as ultrasound beam, needle visible as bright line, and needle beam alignment should be perfect. It should be perfect like this. You cannot go here and here. Perfect like this. Only then you will see it. This is what I meant to say, that if you are in plane in the plane of the beam, you will see the tip, the shaft, and the entry point. But just if you are across like this, you may keep the transducer, see the pocket, and instead of going like this, you are going across like this. You will see just this portion of the needle like an artifact, and you will imagine that this is the tip of the needle. And you will start aspirating, whereas the tip is gone ahead. So this is very, very important principle. If you have control on this, you can do any type of procedures. So this is the transducer aligned 45 degrees in this type of thin beam of ultrasound. And this image, what you saw earlier, entry point you're seeing the parietes, the myometrium, and in the pocket. I already mentioned that you may not visualize after a while. Then what are you going to do is locate the needle. So first, leave the needle alone. You don't have to start moving it here and there that, okay, I'll visualize. No, just leave it alone. Take the transducer and start hunting for it. Then once you have seen, then the probe and needle will go together hand in hand, and then you have seen the entire shaft and the probe, and then you will move the probe and needle together back in line to the target. You'll come back to where you lost from. You lost your path, you will relocate yourself. These are the maneuvers which you may require to do. So align your mind. The operator's skill in aligning the probe and the needle is the most important variable influencing the needle visualization. Now talking about the depth. We spoke about entry point, how you go all the way. Depth is so important because when you are gone in, how much more? You are not going to go in till the needle is there. You are going to go till where it is required. So you must know and measure this depth of your target. Suppose this is your target. So you must measure this. Suppose this is about 8 centimeters. Every machine there are cursors and you have measured that. The trick is from the center of the probe, go 8 centimeters lateral. And from there, 45 degrees and down, like this. And if there is a shallow target, you are going to measure accordingly, go laterally, and this is how it works. So training for invasive procedures should begin on mannequin and simulator. This is one way of doing it. To practice maintenance of the needle path without ultrasound, in the ultrasound window, so that the entire needle remains visible at all times to ensure safety. These are the mannequins you are going to handle. The set is there. This is for transabdominal, this is for transcervical, and these are the procedures which you will get to learn. And when you get back, this doesn't give you a license or PCPNDT. Many people ask me, after this workshop, can I get a PCPNDT certificate? Many have come to attend that also earlier. They thought they will get this certificate and they'll apply for PCPNDT. No, there are norms for that. You have to follow that strictly. So when you get back, it is best to pick up simple cases and better under observation of a person who can guide you, teach you. And then same for CVS, or you could take consent, and sometimes when you're doing an MTP, you can do some transcervical or you can do a transabdominal. So this is what remark I could see in literature, that the minimum number of procedures that is necessary for an operator to perform in order to optimize their components in doing them safely varies in literature from 45 to 300. Till then, you are not really going to say that I am the specialist, okay? So it is also noted that no further improvement is expected after 100. So you should do something better. There is something more better for you to do. this is not for you. If in 100 also you are still not able to align, so God has kept something special for you. Let this people who can do it. So this is our very first workshop we had done at the CMAST. And these were the earlier mannequin. They were quite big, very big. And they have been modified, and these are various workshops. This is in Bangalore, this is in Patiala, and these are the videos which I gave you the link, and I gave you this message already. So most important is, do not advance the needle blindly. Needle tip must be identified before push. Do not swing or jingle the needle to identify the tip. Keep the probe steady during needle movement. These are the mannequins. This is small handbook, very handy, which is going to tell you all this what I have just recited. And this is how we do some small group at my hospital, training as a training center. This is the cannula already described book. So I am here because the person who learns the most in any classroom is the teacher. In every workshop, I have only learnt and gone because such good questions are asked that I say, oh my God, I didn't think about this. Thank you so much. God bless. And now you can thank me.
Sorry, sir. Sorry, sir. Prematurely saying thank you. But